After exploring the medial, lateral, and posterior knee, let us now turn our attention to the intra-articular anatomy of the knee joint. Here we are looking anteriorly on our left knee specimen. As the extensor mechanism is reflected, we see the fat pad and ligamental mucosin just beyond the patellar tendon. Looking at our bony architecture, we can appreciate the asymmetry between the medial and lateral femoral condyles, just one of the factors which allows a smooth, coordinated range of knee motion. We can also appreciate the largest sesamoid bone in the body, the patella, and its articulation with the femoral trochlea. It appears that our specimen had developed some moderate patellofemoral arthritis, as evidenced by the wear pattern on the articular cartilage. Taking down the ligamentum and the fat pad reveals just how far distal from the knee joint the patellar tendon inserts on the tibial tubercle. Before exploring meniscal anatomy, let us focus on the anterior and posterior cruciate ligaments, so named for their tibial insertions. The anterior cruciate ligament, or the ACL, originates on the medial wall of the lateral femoral condyle in the intercondylar notch. It courses distally with its fibers undergoing slight external rotation to insert on the tibia approximately 1.5 centimeters posterior to the joint line. The ACL consists of two discrete bundles, the anteromedial bundle, which is tightest at 90 degrees of knee flexion, and the posterolateral bundle, which is tightest at full knee extension. The anterior cruciate ligament is the primary static stabilizer in resisting anterior translation of the tibia on the femur and plays a lesser role in resisting internal and external rotation and varus and valgus forces across the knee. A common mechanism for ACL injury is a non-contact valgus external rotation force sustained while planning and turning. With the anterior cruciate ligament now excised, we can focus our attention on the posterior cruciate ligament, also made of two distinct bundles, the anterolateral bundle, which is tightest at 90 degrees of knee flexion, and the posteromedial bundle, which is tightest near full knee extension. The posterior cruciate ligament, often referred to as the cornerstone of the knee, is considered the primary stabilizer of the knee because it is located close to the central axis of rotation of the knee joint, and it is almost twice as strong as the ACL. The posterior cruciate ligament is the primary restraint to posterior translation of the tibia on the femur and acts in concert with the posterolateral corner in preventing this posterior translation as well as posterolateral rotary instability. The PCL originates from the lateral surface of the medial femoral condyle in the intercondylar notch and inserts in a depression on the posterior aspect of the tibia extending approximately 1 centimeter distal to the joint line. Note here the PCL section near its tibial insertion and the accessory ligament of Rissberg, which lies just behind it as it inserts on the lateral meniscus. This broad insertion of the PCL is best appreciated in this posterior view of a disarticulated specimen. Although less commonly injured than the ACL, the PCL can be injured with a hyperextension mechanism or an anterior blow to a flexed knee. Let us now return our attention to the wedge-shaped medial and lateral menisci. Each meniscus covers the peripheral 2/3 of articular surface of the tibia and has 4 main functions: to assist with load transmission, to enhance articular conformity, to help distribute synovial fluid within the joint, and to prevent soft tissue impingement during knee motion. The medial meniscus shown here further provides some stability in an ACL deficient knee as the posterior horn resists anterior tibial translation. As shown here, the medial meniscus is C-shaped, attaching anteriorly approximately 7 millimeters anterior to the ACL insertion and posteriorly just in front of the PCL. It is further stabilized by the intermeniscal ligament anteriorly and the capsular attachments peripherally, including the deep MCL, coronary ligaments, and the semimembranosus posteromedially. As a result of these firm attachments, the medial meniscus is less mobile than its lateral counterpart and thereby confers some inherent stability to the knee, while making it more vulnerable to injury in a cruciate deficient knee. Unlike the C-shaped medial meniscus, the lateral meniscus is nearly circular, thereby covering a larger percentage of its respective articular surface and making its removal generally less well tolerated than removal of its medial counterpart. Anteriorly, the lateral meniscus attaches to the intercondylar fossa adjacent to the ACL insertion on the tibia. Posteriorly, it attaches near the PCL insertion, just adjacent to and anterior to the insertion of the posterior horn of the medial meniscus. The lateral meniscus is more mobile than the medial meniscus for two main reasons. Its peripheral attachment is interrupted by the popliteal hiatus, the intra-articular portion of the popliteal tendon, and also there are no direct attachments to the collateral ligament. A controlled mobility of the lateral meniscus is maintained by its anterior and posterior attachments, the meniscofemoral ligaments of Humphrey and Risberg, and the intimate relationship with the popliteal tendon. This concludes our video on the anatomy of the knee joint. We hope you have enjoyed this video while finding it educational as well. We, at the OrthoCarolina Center for Sports Medicine, would like to thank the following people for making this video possible: the OrthoCarolina Research Institute for providing financial support, AV and Photography Services at Carolinas Medical Center for directing and producing this video, Arthritech for donating the cadaveric specimen, the Orthopedic Engineering Research Lab at Carolinas Medical Center for providing lab space during dissection, and finally, Churchill Livingstone Publishing Company.